Hello, this is Glenn Krauss from Core CDI with another great episode of the Clinical Documentation Revolution. And I want to put this in quotes: protecting clinical integrity and preventing denials. Dr. Naz, thanks again for joining me. Isn't that what do we talk about all the time? Uh, Defensible documentation, right?
Absolutely. Yep.
It's not
Defensible
about appealing,
documentation.
hiring more staff to appeal, buying software to send out denials, get to the root cause. So today we want to speak to this. There was a great article in Health Leaders about uh, the CMO's role in the revenue cycle. Okay. And and really, if you think about it, Dr. Nas, CDI programs primarily report to quality, CFO, revenue cycle, HIM. But we've been making a compelling case for this. The CMO must own the intersection of clinical care and financial performance. The
Hmm.
traditional separation between clinical enterprise and the revenue cycle is increasingly untenable. I see that every day. If physicians drive clinical decision making, they necessarily influence the financial consequences of that care. Remember, Dr. Nas, and everyone, nothing, no service can be provided without an order except a screening mammogram. So their decision making on ordering tests, monitoring, treatment, admissions to the hospital, inpatient versus observation, they come from the doctor's order. And so obviously they influence financial consequences of that care. But really, what we should be doing is not chasing revenue by ensuring that the clinical story, here's the kicker here. The clinical story, medical necessity, diagnosis, severity, and services provided are accurately communicated. So I want to have a couple of discussion points for your consideration, Dr. Naz.
Yeah.
Should physician accountability extend beyond quality and safety metrics to documentation and revenue cycle and integrity? And what are your thoughts on holding physicians accountable, engaging physicians in understanding it's not their documentation is not just revenue, it's quality, it's readmission reduction, it's safety, it's good patient care, it's medical legal risk reduction. How do we know we need to hold physicians accountable. What are your thoughts on how do we make it happen?
Yeah. Thank you so much. And thanks for having me. I do want to make one point before I answer the question, and that is this article was fantastic, by
It
the way.
was.
And the central argument in this article is that financial discipline, care quality, and patient safety are not competing priorities. So taking that, I will say absolutely that physician accountability needs to extend beyond, the question that you just posed.
Okay.
But we have to define that accountability correctly, right? So I'm not suggesting that physicians should be responsible for billing claims and
Oh, no,
mastering coding rules or chasing
no.
reimbursement, but physicians should be accountable for ensuring that the medical record accurately reflects the patient's condition, the clinical reasoning behind their decisions, the severity of illness, and why the services provided were medically necessary. This is not a primarily a revenue cycle responsibility. It's a clinical responsibility. Every diagnosis, admission, procedure, treatment plan, decision, they all begin with a physician's judgment. And if that judgment is not clearly communicated, the organization cannot accurately code the encounter, demonstrate the medical necessity, report the quality outcomes, and then ultimately defend the care when it's challenged. It is a cycle. It is a stepwise process that has to happen from the door through the floor, right? Revenue
Absolutely.
cycle integrity is a downstream consequence of the clinical integrity. And the physician owns the clinical truth. From there, CDI, coding, UR, and finance, those guys all help translate and project that truth. So the
Does.
accountability has to be shared. Physicians have to own the accuracy of the clinical story, and the organization has to provide the effective education, the efficient workflows, the useful technology, and the timely feedback, right?
Oh, that
We cannot
absolutely.
give physicians an inefficient system any longer and then hold them accountable when it ultimately fails.
And that leads me to my next, that I agree 100%. So then my question to you is, how can CMOs who have their plates runneth over, how
Mhm.
can they create a culture? And I think the key word here, Dr. Naz, is culture, where
Yeah.
physicians understand that documentation is part of clinical care. It's not an administrative afterthought. And I sense that's what, not all physicians, but uh, a good number, their main role is treating patients, getting them better, getting them back to baseline if they have chronic conditions that are exacerbated, and and something has to give, and and that usually is documentation, unfortunately. So how do we create a culture? That's the key piece. It's not only accountability, it's the culture that physicians understand this is not a burden. This is part of being a physician.
Yeah. So, great question. There's a movie, and in this movie, this guy is he gets in trouble for doing something, and his cellmate in the he's sitting in jail, and the cellmate asks him, how'd you end up in jail? And he says, oh, well, I did X, Y, and Z. And he says, well,
Oh no.
I don't think that. I don't think you did it the wrong. I don't think you necessarily did the wrong thing. I just think that you had the wrong dream. And I think that this is the position that we're living in hospitals. And it's that we have been trying to change culture for so long, but maybe we're just trying to change it the wrong way.
I was just
Maybe
going to
we've had
say, maybe we're not
the
using the right way.
Right. And so this first step is to change the message, right? If physicians only hear about documentation when someone wants a higher case mix index or another diagnosis or another query answered, they're naturally going to view documentation as a financial exercise. The CMO must consistently frame the documentation as clinical communication. It's a different dream, right? The medical record should allow the next physician, the nurse, the consultant, the case manager, and any physician reviewer to understand what is happening with the patient and why it's happening. In addition, education has to be clinically relevant. Instead of us telling a physician that a diagnosis qualifies as an MCC, we'll
Oh
show them
yeah,
that we need to be showing them that the record says respiratory failure, but never explains the oxygen requirement, the
that's
change
right.
from baseline, the respiratory distress, or the treatment being provided, right? The conversation becomes clinical clarity and defensibility and not coding, right? That's the work that we need to be doing. The CMO needs to reinforce this culture through the physician onboarding, through residency education, through
That's right.
specialty meetings, case reviews, individual feedback, right? Our documentation expectations should be incorporated into the normal standards of clinical practice and not introduced only when we have a denial, right?
Yeah,
And we've got to be modeling this behavior. If the documentation is truly a part of quality and safety, then it should receive the same leadership attention as
and
mortality, as readmissions, as infection rates, and patient experience.
you hit a nail on the head. If you're only uh, trying to improve documentation for the diagnosis, physicians, most physicians equate that to what's in it. It's all about the hospital. What about me, right?
Hmm.
Uh, 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 Physicians want to do right. They don't come to work to be poor documentarians. They don't say in the morning, I'm going to get up and do a horrendous job of documentation. They're not getting feedback, and most importantly, they're not receiving instruction on how to be more efficient, working smarter, not harder. Which leads me to my next point. Okay, can hospitals legitimately expect the CDI programs and the software, the coding and the revenue cycle departments to fix documentation after the fact? And I don't mean after the fact, meaning the patient's discharge, although I see that. Uh, it's really CDI is transactional, repetitive, reactionary. After the documentation's in the chart, then we go ask, hey,
Mm.
is this sepsis with septic shock? Hey, doctor, does this meet the definition of moderate malnutrition? Right? So why is that not working? Is it legitimate that this can work? What are your thoughts? You've been in this as just as long as I have.
No, they can't. They can't. Those teams can clarify a record, but they can't recreate a clinical encounter, right? CDI can identify a gap and ask some compliant question. Coding can translate documented diagnosis into a code. UR can evaluate whether the documented facts support level of care, and denials teams organize the evidence, right? But none of those teams can independently establish a diagnosis. They can't invent a cause and effect relationship. They
Nope.
cannot document clinical reasoning that a physician never expressed, right? These teams are essential, and retrospective intervention can create a lot of inefficiency, right? The physician often receives queries several days later, weeks later, when the details aren't fresh. Right? The question might feel disconnected from the care. And
Right.
eventually, organizations develop query fatigue, and not eventually, they're already developed it
Yeah, they're
everywhere.
doing that. They're burnt
All
out, Doctor
six
Doctor
thousand
Nas.
hospitals. Yeah, 6,000 hospitals in the US. And how many of them will say, "Oh yeah, give me more queries"? I gotta
Yeah.
ask.
Hey, what doctor gets? Hey, CDI, can you issue more
Yeah,
queries, please? I love them. And you
yeah.
know
I
what I'm
mean,
finding, Dr. Nas, is
uh,
that you put a query in front of a doctor, they're so fatigued, they check off the first thing and don't necessarily read it.
That's right. That's right. So
Query,
the better question is not how do we build a larger department to catch every documentation failure? It's how do we design the process, the clinical process, so the right story is documented correctly the first time.
that's right. Which leads me to my last point. If the physician owns the clinical decision, as we just spoke, shouldn't the physician also own the accuracy and completeness of the clinical story that supports that decision? That's a
Y-
question for
Yeah.
CMOs. And I know
Yeah.
it's a rhetorical answer. If the physician owns the clinical decision, inpatient versus observation versus discharge, right?
Yeah.
Should the physician also own the accuracy and completeness of the clinical story that supports the decision? That's where the disconnect. I see that every day. What about you in your practice in reviewing
Absolutely.
records? It's like, where did the doctor come? Where did that come from?
Absolutely. This is a part of professional accountability, right? The ownership doesn't mean isolation, though. So we should clarify, right? The physician owns the clinical judgment and the truthfulness of the record, and the organization owns the environment in which that documentation occurs, right? The CMO has to ensure that physicians know what good documentation looks like,
That's right.
that expectations are consistent, that the EHR makes it reasonably easy to capture, and then CDI coding, UR, and the physician advisors should provide support, education, and feedback, right? We can't
Absolutely.
just blame physicians for every
No,
denial. Some of the denials are inappropriate, some payers are unreasonable, and some problems originate in coding, they originate in the workflows, they originate in the technology. It's ultimately about recognizing that no downstream department can fully compensate for a clinical story that was never told.
that's right.
So
It's like Dr. Nas. It's trying to resurrect a record that's dead.
that's right.
It's
So if
dead.
we Yeah, and if we want physicians to retain ownership of the clinical decision making, we also have to accept responsibility for communicating those decisions clearly and accurately and very completely. And so,
Absolutely.
that's my message to CMOs.
And so really, I want to close with this. This has been great. Dr. Nas, here's a takeaway. As I mentioned, if the physician owns the clinical decisions, they should also be responsible for documentation of their decisions. And I've seen several cases where I worked on behalf of the defendant attorney in a malpractice where the doctor came up with a diagnosis, or they supposedly ruled out a diagnosis, but
Mm,
they never told us why. So
mm,
one of them was a delay in diagnosing, and the other case was a misdiagnosis. But it wasn't missed. The doctor didn't say why he ruled out a diagnosis, so it looked like he missed the diagnosis.
mm.
Uh, it's a medical legal issue too. So I want to say to close with this, Dr. Nas and everyone, the goal should not be more diagnosis or higher case mix index. It must be accurate diagnosis supported by the patient's clinical picture and the doctor's expression and accurate reporting of their clinical judgment, medical decision making thought processes. That's what being a physician is all about. That's why I
Absolutely.
have all these years of experience. Dr. Naz, I appreciate your time. I'd like to revisit this in a later podcast because there's several other areas we'd like to discuss. But everyone, we had several podcasts already, Clinical Documentation Revolution. Please refer to the core-cdi.com website. And Dr. Naz, thank you so much for your time. Everyone, if you're a physician, CDI, you are listening, we thank you for your work. It's not easy in today's environment, carrying out what we need to do. Have a
That's
great
right.
day. Bye-bye.
Thank you. Bye.